welcome to this presentation, Fetal Development, Monitoring and Intervention. So from cell to baby, how your baby grows in the womb, a week-by-week journey. Weeks 1 to 4, the very beginning. First we have fertilization and implantation. So conception happens when a sperm fertilizes an egg, forming a single cell, with all the DNA needed to become a baby. This cell divides rapidly and travels down the fallopian tube to implant itself in the lining of the uterus. At this point, the embryo stage begins, and by the end of week 4, the embryo is about the size of a poppy seed, and the basic structures of the brain, spinal cord, and heart start forming. Weeks 5 to 8, foundations are laid. At this stage, the embryo grows to the size of a raspberry, limb buds appear and will become arms and legs, and the heart begins to beat at around week 6. Major organs like the brain, liver and kidneys start forming. Eyes, nose and mouth start to take shape. The neural tube, which becomes the brain and spinal cord, closes by the end of week 6. Week 9 to 12, now a fetus. At week 9, the embryo becomes a fetus. The fetus grows to about the size of a lime and begins to move, although it's too small for the mother to feel it right now. Fingers and toes separate, external genitalia start to form, and the heartbeat can often be heard at this stage with a Doppler device. Weeks 13 to 16, rapid growth. At this stage, the fetus is about the size of an avocado. They appear more human-like with well-defined facial features. Bones begin to harden and muscles get stronger. The fetus may begin to see light and sound. Weeks 17 to 20, feeling the first kicks. The fetus is now the size of a banana. A fine hair, called lanugo, covers the body and eyebrows, and scalp hair begin to appear. Mum may start to feel flutters called quickening as the fetus starts to hear external sounds, including the mother's voice and heartbeat. Weeks 21 to 24, developing survival skills. About the length of a corn, the fetus starts to develop air sacs, although breathing will only be possible after birth. They begin to have regular sleep and wake cycles and can sense flavours in the amniotic fluid. Weeks 25 to 28, getting stronger. Around the size of an aubergine, the baby's movements are more noticeable and coordinated. The eyes start to open and respond to light, and their brain is rapidly developing, with brain waves showing response to sound and touch. Weeks 29 to 36, almost there. Babies the size of a cabbage and fat stores have begun to accumulate under the skin for warmth. Lungs and brain are maturing significantly, with the baby practicing breathing movements. Baby responds to familiar voices, music and light. Weeks 37 to 40, ready for birth. Baby is full term and organs are fully developed. In most cases, baby is positioned in head down position, responds to light, sound and touch. The average weight of a baby when born is between 6 and 9 pounds. Any questions? Now is the time to pause this video and write down or discuss with your care team any questions you may have in relation to the stage of development of your unborn baby. Monitoring your baby's growth, ultrasound, Doppler and fundal height. So, why do we monitor the fetus? We do this to ensure baby is developing safely, to detect any complications early and to support the best outcomes for both mother and baby. There are several simple, safe and non-invasive ways your healthcare provider can monitor your baby's growth and well-being throughout pregnancy. These include ultrasound, Doppler imaging and fundal height measurements. Ultrasound, a window to the womb. An ultrasound is the most common and widely used imaging method during pregnancy. It uses waves to create live images of your baby. You can expect to have a scan in early pregnancy, around 6 to 12 weeks, mid-pregnancy, 18 to 22 weeks, which is the anatomy scan, and if needed, in the later weeks of pregnancy. It shows the baby's size and growth overall and of their organs and limbs. the placenta and amniotic fluid, and can also determine the baby's sex if you want to know. Doppler ultrasound, listening to the heartbeat and blood flow. So what is a Doppler ultrasound? A Doppler ultrasound is a special type of ultrasound that measures blood flow in the umbilical cord, placenta, and baby's heart and brain. It is used often from the second trimester onward if there is concern about the baby's growth, the mother has high blood pressure or other medical conditions, or there is a history of pregnancy complications. This type of ultrasound is useful as it can show how well blood, and therefore oxygen and nutrients, are flowing from the placenta to the baby, and monitors heart function in more detail. Fundal height measurement, a quick and simple check. What is it? Fundal height is the measurement in centimetres from the top of the pubic bone to the top of the uterus, the fundus. It is used usually from around 20 weeks of pregnancy onwards and measured at each prenatal visit. The fundal height typically matches the number of weeks pregnant. For example, if you're 28 weeks gestation, you would expect to be measuring 28 centimetres or thereabouts. A measurement significantly higher or lower might suggest a larger or smaller baby than expected, too much or too little amniotic fluid, and any of these may highlight the need for further testing or ultrasound to check on baby's growth. Fundal height is helpful as it's a quick, non-invasive way to track growth and alerts the healthcare provider to any potential concerns, which helps ensure both the mother and baby are staying on a healthy path. Questions. Now is the time to pause the video and write down any questions to discuss with your care team or any concerns about monitoring or scans. Fetal monitoring during labour. Understanding how we keep your baby safe during the birthing process. What is fetal monitoring? Fetal monitoring involves checking your baby's heart rate and your contractions during labour to ensure that your baby is coping well and not in distress. It helps your healthcare team make safe, timely decisions if any concerns arise. My apologies. There we are. Types of fetal monitoring. One is continuous electronic fetal monitoring, or CTG. This method uses electronic sensors placed on your belly to monitor your baby's heartbeat and your contractions continuously. The results appear on a screen and a printout so your care team can constantly check how your baby is responding to labour. CTG is often used if you have high-risk pregnancy, there are concerns about your baby, or if you're being induced or have an epidural. You may need to stay on or near the bed during this type of monitoring, although some hospitals offer wireless monitors that let you move more freely. And 2 is intermittent oscillation. This is a simple non-invasive method. A midwife will use a handheld device like a Doppler or a pinhead stethoscope to listen to your baby's heartbeat at regular intervals, usually every 15 to 30 minutes during active labour and more frequently as birth gets closer. It's often used in the case of low-risk pregnancy. The benefit of intermittent oscillation is it allows you to move around more freely, enabling the use of more varied birthing positions or water for comfort. So monitoring during labour, stage by stage. Early labour. During this time you may be at home or in hospital. Intermittent monitoring is usually used, for example, with a handheld Doppler. The midwife will check baby's heartbeat every 15 to 30 minutes. Active labour or established labour. At this stage, monitoring becomes more regular. At this point, the options include CTG, continuous electronic fetal monitoring, or intermittent oscillation as discussed in the last slide. Second stage, the pushing phase. Monitoring will continue, often more frequently, which helps to ensure baby is handling the pressure and contractions well. So when is extra monitoring advised? Your care team may recommend extra or continuous monitoring if there are complications, such as high blood pressure or diabetes, preterm labour, slow or fast progress in labour. If baby shows signs of distress, such as irregular or abnormal heart rate, if labour is induced, you're having twins or multiples, if meconium is present in the amniotic fluid, or if you choose an epidural, which may slightly increase the need for closer monitoring. Internal monitoring, used when needed, only when needed. If external monitoring isn't giving clear readings, an electrode may be gently placed on baby's head after waters break and cervix is dilated. This gives a more accurate picture of baby's heart rate. How monitoring can change the birth plan. Monitoring may show that the baby is not getting enough oxygen, becoming tired from contractions, or reacting to medications. In these cases, your care team might recommend changing your position to improve blood flow to baby, reducing or stopping induction medication, providing fluids or oxygen. They may also recommend speeding up delivery using assisted delivery, either forceps or suction ventouse, or an emergency cesarean if necessary. Your choices matter in keeping your baby safe. During your labour, you'll be informed and included in all decisions. Your care team will explain the reasons for any changes, and even if the birth plan changes, your preferences such as pain relief, birthing position, or immediate skin-to-skin contact will be respected as much as possible. In summary, monitoring equals safety and support. Fetal monitoring helps ensure the safest birth possible for both you and your baby. It can guide important decisions and allow quick action if needed. The goal is always a safe, supported and positive birth experience. So questions. Let's now pause the video and discuss or write down your thoughts, questions or concerns. We're here to help you feel confident and prepared. So understanding prenatal screening, chromosomal abnormalities, genetic conditions and fetal health. What is prenatal screening? Prenatal screening is a way to assess the health and development of your baby during pregnancy. It helps identify genetic or chromosomal conditions early and supports informed choices and planning. Chromosomal abnormalities, what are they? These occur when a baby has extra or missing chromosomes. We screen for the three most common. Down syndrome, trisomy 21, caused by an extra copy of chromosome 21. It can lead to learning difficulties, characteristics, facial features, and potential heart problems. Edward syndrome, trisomy 18, caused by an extra chromosome 18, often leads to serious physical and developmental issues. Many babies sadly do not survive long after birth. Fetal syndrome, trisomy 13, caused by an extra chromosome 13, can result in severe brain, heart and facial abnormalities. In most cases, life expectancy is very limited. So how are chromosomal conditions screened? In your first trimester, there is a combined test, an ultrasound scan to measure nuchal translucency, fluid at the back of the baby's neck, and a blood test to check hormone level of HCG and PAPA. These tests, combined with maternal age, estimate the chance of trisomy. In your second trimester, there is a quad test if the combined test was missed, which is a blood test measuring 4 substances in the mother's blood. If results come back as low risk, no further tests will be required. If they return as high chance, you'll be offered further diagnostic tests. So diagnostic testing if high risk. If screening suggests a high chance of chromosomal abnormality is found, parents will be offered chorionic villus sampling done from 11 weeks, amniocentesis done after 15 weeks. These tests involve taking a sample of placenta or amniotic fluid to look directly at the baby's chromosomes. Genetic screening, sickle cell anemia. Sickle cell is a common inherited blood condition more likely in African, Caribbean and Middle Eastern and Asian families. All pregnant women are offered a test in early pregnancy, and if the mother is a carrier, the baby's father is also tested. If both are carriers, there's a 1 in 4 chance the baby will have the condition. So what is sickle cell anemia? Fetal anemia is a condition. Sickle cell affects red blood cells, making them sickle-shaped. This can block blood flow, cause pain, infections, and anemia. What is fetal anemia? Fetal anemia is a condition where the baby doesn't have enough red blood cells. This can result from infections, genetic conditions, or blood group incompatibility, such as rhesus disease. So how is fetal anemia screened and treated? An ultrasound scan can be used to measure blood flow in a brain artery. Amniocentesis, where a small amount of amniotic fluid is sampled from the uterus, may be used to check the baby's blood type or infection status. It can sometimes be diagnosed when the mother has conditions like parvovirus or rhesus antibodies. If fetal anemia is confirmed, you may be offered to deliver early if baby is far enough along, or you may be offered a treatment which is highly specialised and can be life-saving, called intrauterine transfusion, where blood is given directly to baby via the umbilical cord. Your care, your choices. Screening is optional and support is always available. The results of these screenings help you make informed, empowered decisions for you and your baby. You'll never be alone, and your care team will be with you every step of the way. So any questions? We're here to support you. Take a pause and write down or discuss with your team any questions or concerns you may have. So trigger warning. In the next slides, we're going to discuss miscarriage and termination. Some parents may find these contents upsetting. Your healthcare team are available for support. So what is miscarriage? A miscarriage is the loss of a pregnancy during the first 23 weeks. Sadly, it is more common than many people realise. Around 1 in 4 pregnancies end in miscarriage, often before someone even knows they're pregnant. Miscarriage is most often caused by natural factors beyond anyone's control. So common risk factors for miscarriage. Miscarriage can happen for many reasons, and it is very rarely due to anything a parent has done. Some factors that can increase the risk include chromosomal abnormalities in the baby, maternal age as the risk increases after the age of 35, previous miscarriages, so having 2 or more can slightly raise the risk, and chronic health conditions such as uncontrolled diabetes, thyroid disorders, or autoimmune diseases, certain infections like rubella or listeria, and lifestyle factors such as smoking, heavy alcohol use, and drug use. What doesn't cause a miscarriage? There are many myths surrounding miscarriage, so let's clear up a few of the common misconceptions. Exercise. Safe, moderate exercise is encouraged during pregnancy. Sex. Having sex does not cause miscarriage in a healthy pregnancy. Stress or worry. Everyday stress is not a cause. Working or lifting light objects. These are usually not harmful. It is really important to remember miscarriage is rarely caused by something you did or didn't do. How to reduce the risk of miscarriage where possible. While you can't always prevent miscarriage, there are things you can do to support a healthy pregnancy. Take folic acid before and during early pregnancy. Maintain a healthy weight. Manage existing health conditions with your doctor. Avoid smoking, alcohol, and recreational drugs. Eat a balanced diet and follow food safety advice. And keep up with prenatal appointments and screenings. So what happens after miscarriage? Depending on how far along the pregnancy is and how the miscarriage occurs, treatment options may include natural or expectant management, letting the body pass the pregnancy tissue naturally. This may take a few days to a few weeks. This option will be suitable if there are no signs of infection or heavy bleeding. Medical management. Medical management is used to help the womb pass the tissue. This is often done at home and may result in cramping and bleeding like a heavy period. Surgical management, a minor procedure called ERPC, evaluation of retained products of conception. This will be done under general or local anaesthetic. It is quick and effective, often used if bleeding is heavy or tissues remain. Your doctor will explain the safest and most suitable option for your individual situation. Emotional impact and support. A miscarriage can be emotionally overwhelming. You may feel sadness, guilt, confusion, grief, or numbness. You are not alone, and support is available from midwives or GPs, counsellors or therapists, or support groups such as Tommy's and the Miscarriage Association. Any questions or concerns? We're here to support you when you need us. Please write down or discuss anything on your mind at your own pace. Understanding termination of pregnancy for parents who may need to make difficult decisions. A termination may be considered for various reasons, often related to health or personal circumstances. These decisions are deeply personal and can be guided by the health of the parent and baby. Some situations include health of the parents, life-threatening conditions, severe medical issues such as cancer, heart disease, or organ failure may make carrying a pregnancy unsafe for the parent's health. Severe mental health conditions. Some conditions may seriously affect the ability to care for oneself or a baby. The health of the baby. A termination may be considered if there are chromosomal abnormalities or serious genetic conditions, for example trisomy, are detected and the baby's prognosis is incompatible with life or would lead to extreme suffering. Severe birth defects that would cause significant suffering for the baby or greatly reduce their quality of life. Unforeseen or crisis situations. Unplanned pregnancies that are not viable for social, emotional, or financial reasons, though this is a highly personal decision. Cases of rape or incest. In some countries, a legal option to terminate is offered in cases where conception occurred through violence. Gestational age limits. Termination is generally legal up until 24 weeks in many places, but this can vary on local laws. After 24 weeks, termination may only be allowed if the mother's life is at risk or if the baby has a fatal condition. Medical termination of pregnancy. Medical termination involves taking medication to end the pregnancy. This process is typically used in early pregnancy, up to 10 weeks gestation. How it works. Day 1, the first medication, mifepristone, blocks the hormone progesterone, which is needed for the pregnancy to continue. This medication causes the lining of the uterus to break down and the pregnancy to stop growing. 24 to 48 hours later, the second medication, misoprostol, is taken at home or at the clinic, which causes the uterus to contract and expel the pregnancy. It can cause cramping and bleeding similar to a heavy period. A follow-up appointment is scheduled to ensure the pregnancy has been fully terminated. If necessary, further treatment or a surgical procedure may be recommended. Advantages and considerations of medical termination. Medical termination is non-invasive and can often be done at home, and is a quick process, typically completed in 2 days. Physical side effects may include cramping, bleeding, nausea, and fatigue. Emotional reactions will also vary, although support is available. Surgical termination of pregnancy. A surgical termination is usually performed when medical termination isn't possible, typically after 10 weeks gestation. Vacuum aspiration, up to 16 weeks. This procedure takes 10 to 15 minutes and is performed under local or general anaesthesia. A suction device is used to remove pregnancy tissue. Dilation and evacuation, after 16 weeks, a more complex procedure for later pregnancies where surgical instruments are used to remove tissue. Advantages and considerations of surgical termination. It is a quick procedure, often completed in one visit. It is also a well-established and safe method. It does, however, require anaesthesia and recovery time and can cause possible side effects, such as bleeding, cramping, or infection. Emotional and psychological support. It is normal to feel a range of emotions during this time, and support is crucial and available. There is counselling, either individual or group, support like BPAS or Mary Stopes, hotlines for mental health support, and healthcare providers offer ongoing emotional care. Any questions or concerns? We're here to provide support and guidance during this time. Feel free to ask questions or talk through or write down any questions or concerns. Thank you.